With regard to diabetes mellitus, the situation as of today is the following. In the best possible way, patients are these days treated with a long-acting basic insulin, basal insulin, and then they get shots during their meals, which is as good as it can be. Nevertheless, this is lacking a physiological control of blood sugar, which you can only accomplish by having an insulin-producing cell line which would respond physiologically to a high blood sugar. Now, by encapsulating insulin-producing cells and giving those capsules into the body of a patient with diabetes mellitus, you would precisely mimic this physiological need, that is to say, to have a responsive insulin-producing cell within the body. I would foresee that this would be the drug of choice for all the patients who have no further insulin regulation left. That is, certainly all of the patients who have got rid of their entire pancreas, because those lack the physiological regulation of not only the insulin but also the counteracting hormones like glucagon. So giving them back the entire set of hormones, insulin, glucagon and the like, would certainly avoid all of the complications with which these patients typically see. Hyper but also hypoglycemia. And then, of course, long-standing patients with insulin-dependent diabetes mellitus are another group of patients who certainly would profit from this kind of therapy. The problem when we first invented this technology was that you couldn't freeze down the capsules. I mean, the capsules you could freeze down, but you couldn't freeze down the cells and thaw them. So, and this process could not be controlled in the appropriate quality control fashion which you have to have in place once you would like to produce this as a drug and sell it, So we couldn't really make the step from an, say, academic, early biotech kind of production of these encapsulated cells to a fully fledged biotech quality controlled process where you could basically take whatever encapsulated cell off the freezer. It had to have a best before date, was like a yogurt, and this kind of best before date was rather short. Most of the anti-immunological therapies, that is what drugs you use in transplantation, and this of course would be a transplantation if you use, say, xenographic, which you certainly shouldn't do, but even allogenic cells from other man. The immunosuppressants altogether have severe side effects. The one which is most popular, cortisone, in itself is causing diabetes mellitus. So by avoiding that patients have to take long-term drugs with significant side effects, again, is improving the quality of life and also avoiding secondary diseases and conditions which in turn have to be treated. It's a dream of a lifetime for a physician to really develop something from the bench to the bedside, and this is what we did 20 years ago. And the shortcoming was really the technology at that time. We couldn't possibly get this produced in a way that it could eventually become an ordinary drug, something you could sell and buy. We have the chance to really offer something reliable which we can use in clinical studies and hopefully later on in routine clinical care. And that in itself is very exciting. It's a very brave thing that somebody is taking up this platform technology, which I think has a lot of future and will very, very much change the life of many patients in the future.